Welcome to the Community Nursing webinar, Supporting Diabetes Care in the School Setting. My name is Sean Barrett, and I'm a clinical nurse specialist with the diabetes team at SickKids Hospital. Today, I will be sharing the slides that were created by myself and my CNS colleague, Denise Penny. This webinar aims to share the management goals for pediatric diabetes care, review the typical daily care routines for children with type 1 diabetes, examine the common devices used to monitor glucose levels and administer insulin, and highlight urgent situations that could occur in the school setting, as well as discuss non-urgent school situations that the family and/or diabetes team can follow up on and or plan for. The overall diabetes management goal is to achieve as close to normal blood sugar control as possible with a glucose target range of 4 to 8 millimoles per liter before meals. Factors that impact this balance include food, activity, and insulin. Carbohydrate foods raising blood sugar levels, while insulin and activity generally lowering blood glucose levels. Each child's insulin dosing plan is matched to their individual food intake and activity routines to try to establish blood glucose levels mostly in the normal non-diabetes range. Dietary management is an important cornerstone of diabetes care. With the guidance from a dietitian, families are educated on the relationship between carbohydrate foods and blood sugar levels, the importance of timing insulin administration to food intake, and how to best match carbohydrates to insulin. This dosing is usually done using an insulin to carbohydrate ratio. Eating a balanced, healthy diet by following Canada's food guide is encouraged, as opposed to following a different diabetic diet. Monitoring blood sugars is an essential component of type 1 diabetes daily treatment routines. Tracking of glucose levels not only helps determine if a specific action needs to be taken at that moment, but also supports ongoing insulin dose adjustment that can lead to overall better management. Currently, children with type 1 diabetes monitor their blood sugars at a minimum of 4 times a day, before meals and bedtime. This can be done with a glucose monitor. However, more children are now wearing continuous blood glucose sensors that track glucose levels every 5 minutes and display this information on a receiver or cell phone. These devices have become much more accurate, easier to use, and accessible through government funding like OHIP Plus. The administration of insulin is the next daily routine that children with type 1 diabetes engage in. Currently, a multiple daily injection or MDI routine that involves administering insulin with a pen device 4 times a day is utilized, since it has the potential for the best blood glucose control and provides the most flexibility. Continuous subcutaneous insulin infusion therapy or insulin pump devices are now utilized much more by children with type 1 diabetes, with the potential to meet even more management goals while also improving quality of life outcomes. An MDI routine involves taking fast-acting insulin with the 3 main meals to match carbohydrate consumption at these times, as well as the administration of 1 daily dose of long-acting insulin to manage the blood sugars in between meals and primarily overnight. This slide goes over the details of what insulins we would utilize in an MDI routine. Currently in Ontario, biosimilar insulins, which are a biologic copy of original insulin and available at a much lower cost, are what OHIP Plus is covering. Because of this accessibility, these types of insulins are currently initiated in newly diagnosed children with Admelog or Trurapi being used for the fast-acting insulins and Basaglar being used as the long-acting insulin. Tresiba, which is a long-acting insulin analog lasting up to 42 hours, is being used more often as well. Insulin pump therapy utilizes only fast-acting insulin. The continuous infusion that the pump delivers is called the basal rate, and similar to long-acting insulin in an MDI routine, it's responsible for keeping the blood sugar in range in between meals and snacks, and primarily is what manages blood sugars overnight. However, unlike an injection of long-acting insulin, the basal rate can be delivered in small, varying increments per hour, which can be adjusted based on the individual's needs. The other piece of insulin pump delivery is the bolus dose of insulin, which is given with carbohydrate foods and in situations when the blood sugar needs to be corrected. These doses require the person to confirm the delivery of a certain amount of insulin calculated by the pump that is based on the carbohydrate intake and the blood sugar level at that time. This slide better highlights what details would be provided in a typical school nursing order calculating the fast-acting insulin dose at lunch, whether a child is taking insulin injections or wearing an insulin pump to manage their diabetes. An insulin to carbohydrate ratio, or ICR, is needed to calculate the amount of insulin to cover a certain amount of carbohydrate food. This is written as the number of grams of carbohydrates covered by 1 unit of insulin. For example, an ICR of 1 unit for every 15 grams of carb means that 1 unit is needed for every 15 grams of carbohydrate eaten. So if a child is planning on eating 45 grams of carb at lunch, then this total amount would be divided by 15, and in turn they would have 3 units of fast-acting insulin. Parents should label the amount of carbohydrate in each food item to support easier calculation at lunch. Well, an insulin correction factor, or ICF, is an estimate of how much 1 unit of insulin will lower the glucose level. It does require that a glucose target is provided to do this piece of the dose calculation, and if easier, this can also be translated into a correction or insulin sliding scale. For example, an ICF of 3 millimoles means that 1 unit will lower the glucose by 3 millimoles per liter. If a child's blood sugar is 12 and their target blood sugar is 6, they would need an extra 2 units of fast-acting insulin to bring their blood sugar down into target. I also just wanted to point out that there are apps to support these dose calculations, which we've received feedback is very helpful to use in a busy school setting. The one up on the slide right now is from BC Children's Hospital, and we encourage a lot of our families to use this at home as well. In reviewing the typical daily routines of children with type 1 diabetes, the following details should be provided in the school nursing order and reviewed when caring for children in the school setting. First, glucose monitoring routine, whether the child is using a meter or a sensor to monitor their blood sugar and how independent they are with this skill. Insulin treatment routine, whether the child is using an insulin pen for injections and whether they are taking a fixed dose at lunch or using an insulin to carbohydrate ratio with an insulin correction factor or insulin sliding scale. There may sometimes be an order for basal insulin to be administered as well. Around the pump order, we need to have an insulin to carbohydrate ratio, an insulin correction factor, and a blood sugar target. And then around dietary management, it's important to relay if the child is involved in counting carbs or needs support with that. Again, having that information labeled by parents and just ensuring adequate PO intake, especially for younger children. To try to bring all of this content to life, we have a case scenario. So Mohammed is a 7-year-old boy who was diagnosed in the summer with type 1 diabetes, and he's requiring full support with his lunchtime care routines. The nursing orders are as follows: to monitor his glucose with the CGMS, he's wearing the Dexcom sensor, to administer insulin following an insulin to carbohydrate ratio, which is 1 unit for every 9 grams of carb at lunch, and to use an insulin correction scale, which is highlighted here, suggesting increases in doses ranging between blood sugars of 4 all the way up to over 18. So at lunch, Mohammed's food is labeled to have 47 grams of carb in it, and his blood sugar reading is 12 when you check it with him before lunch. Just as a reminder, his carb ratio is 1 unit for every 9 grams of carb, and he has his insulin correction scale. So the questions we have are, first, all sensor readings should be confirmed by the child's meter. This in fact is false. We're able to follow the information and make treatment decisions from CGMSs. They are that accurate and approved to be used in those situations. So we don't necessarily need to do verify what the glucose reading is with a blood sugar monitor. The second question is just asking about how much insulin would be needed for Mohammed's lunch meal. And just as a reminder, he was having 47 grams of carb and his carb ratio was 1 unit for every 9 grams. So if we do this calculation, Mohammed would have 5 units if we divide 47 by 9 grams. And then for the sliding scale, his blood sugar is 12. So if we follow the sliding scale, we would add a half a unit to that. So he would need 5.5 units for lunch. In the following section, we're going to review the management devices you will see and interact with for children with diabetes, including continuous glucose sensors, insulin pens, and insulin pumps. To start, a sensor is a device that measures the interstitial glucose levels, which are the sugar level in the fluid between the cells, without needing the child to have to poke their finger. A small, flexible wire is inserted under the skin to measure glucose. A transmitter sits on top of the skin and sends the glucose readings to a device where the information is displayed. You have the option of using a small handheld device called a reader or receiver, or to see this information, or even look at this information on an app on a smartphone. Some parents will also have follow-apps that allows them to see their child's blood sugar levels while they're not with them. This is only for those who are using the phone app, though, as the receiver. This slide better illustrates why a sensor, which measures glucose in the interstitial fluid, will provide slightly different glucose values compared to a standard blood sugar monitor, which measures glucose in a drop of capillary blood. To understand the difference in timing between these measurements, focus in on the photo and look at the orange circles which represent glucose. Imagine eating an apple. As the apple is digested and the carbohydrate content breaks down into glucose, it first travels through the bloodstream and then a few minutes later moves from the blood into our interstitial fluid. This can take anywhere from 5 to 10 minutes and is referred to as lag time. Since this physiological difference exists, a glucose value attained from a finger poke and checked on a meter versus one attained from a sensor and transmitted to a receiver will not be exactly the same. Despite this unavoidable discrepancy, the accuracy with the sensors used today has been well validated and approved by Health Canada to make treatment decisions and dose insulin for school-aged children and older. These are the 3 standalone continuous glucose monitoring devices available in Canada currently. So the Freestyle Libre 2, the Dexcom G6, and more recently, the Dexcom G7. This slide shows that attaining a glucose reading may be a little different depending on which device and receiver is being used. When children are using the Freestyle Libre 2 sensor with a reader, which is shown on the slide here, device as the receiver, so not the phone app, they will need to physically scan the sensor with the reader to see the current glucose value. However, more recently, if a child is using a phone app as a receiver with the Libre 2 sensor, the glucose level will be continuously updated on the app every 5 minutes. This is just like the Dexcom G6 or G7 CGMS, which pushes the glucose reading to the receiver, whether this is transmitted to a standalone device or a cell phone app. Both types of sensors provide an update of the blood glucose every 5 minutes and also indicate the direction that the blood sugar is moving in the next 15 to 30 minutes. This is very helpful in planning for activities such as recess or gym class and making treatment decisions, especially if the blood glucose level is in target and decreasing quickly. As well, each sensor is equipped with alarms that families can set when the blood sugar reaches a certain number, helping to give parents reassurance that a low or high sugar will be identified when their child is less aware, such as overnight or during recess at school. Here's a screenshot of the Dexcom transmitter, which could be a standalone device or viewed through a mobile app. As you can see, it displays the most recent blood glucose with a trend arrow and then shows a trend of the last 3 hours of blood sugars in the dotted line at the bottom of the screen. The gray section is the in-target range of 3.9 to 10, which is the target range for people on sensors because this is looking at the blood sugars any time of day. The red shaded area is below 3.9 and the yellow section is above 10 millimoles per liter. The Libre 2 sensor also provides similar information, whether people use a reader or a phone app to provide them with these details. As mentioned before, the main advantage of using a phone app over the reader device is that you do not need to scan the sensor to attain the glucose reading. Now, just to switch gears, we're now going to review insulin administration devices, starting with the insulin pen that has completely replaced giving injections with a syringe. Each insulin brand has their own pen device that the insulin cartridge or pen fill can fit into. Although the convenience and accessibility of disposable or pre-filled pens makes them the obvious first choice, for children who require half-unit doses, a reusable or non-disposable pen that can dial up doses in half units is needed. I just wanted to highlight the Canadian FIT guidelines that recommend best practices for insulin administration using pen devices, including techniques specific to the pediatric population. Also, just to mention, during the administration of insulin at school, this is a really great time to remind children the importance of rotating injection sites, as they often have a favorite site which can be overused and then lead to the thickening of the fat tissue and insulin not being absorbed properly. Next, we'll review insulin pump therapy, with this illustration showing the main components of how pumps operate. With an infusion set sitting on the skin and anchoring the cannula into the fat tissue, these devices continuously infuse or pump fast-acting insulin, which replaces basal insulin in an MDI injection routine. When the person with diabetes eats or needs a correction of insulin, they interact with the pump, letting it know that they are eating and what their blood sugar level is. Then, based on program pump settings such as the insulin to carb ratio, insulin correction factor, and target blood sugar, the pump will calculate a bolus dose of insulin which the person needs to confirm and approve the delivery of. Here are some more pictures to show pump infusion sets, some with tubing that can be disconnected at the site, shown in the bottom right corner, and some that are tubeless, which is the Omnipod pump, shown in the top right corner. All infusion sets are changed every 3 days by families at home, and sites are similar to those used for insulin injections. The next generation of Health Canada approved pumps, called hybrid closed loop or HCL, include a sensor that communicates with the pump to adjust the amount of insulin being infused based on an algorithm that tries to maintain blood sugar levels in target as much as possible. These are also called automated insulin delivery pumps, which increase or decrease insulin delivery based on glucose readings. People still need to interact with the pump to give insulin boluses at meal and snack times and to correct high blood sugars. As well, pump setting changes still need to be made ongoing. This chart shows the 3 pump brands that we currently see in our pediatric population and are funded by the Ministry of Health's Assisted Device Program, or ADP. The pump companies include Medtronic, Omnipod, and Tandem. There continues to be more and more children whose families have chosen to use DIY looping or closed systems. These systems have been around since 2014 and were developed by people in the diabetes community. They use self-built phone applications to enable 2 independent devices, the pump and the sensor, to communicate. Since DIY looping is not approved by Health Canada, support for this currently lies with the developers and those with experience with these systems. Regular follow-up and support with setting changes is still necessary by pediatric and diabetes teams. Currently, the devices that are being used include the Omnipod pump and the Dexcom sensor. So next we have a scenario that you'd likely see in your caseload. So you're visiting a 6-year-old client who has recently been started on an Omnipod pump. She also monitors her sugars using a Libre 2 sensor. Her school nursing orders are to check the blood sugar using the Libre 2 sensor before lunch and to give a bolus of Admelog insulin using an insulin carb ratio of 1 unit for every 15 grams at lunchtime. So what information do you need to enter into the pump at lunchtime? A, glucose if sensor doesn't communicate with the pump. B, carbohydrate amount. Or C, both glucose level and carbohydrate amount. And the answer is C. You need to enter both of that information into the pump because the Libre 2 sensor currently doesn't communicate with this type of pump, and we would need to let it know what the blood sugar value is, as well as the amount of food that the child's eating at lunch. Question 2, do you have to do the manual calculation of dividing the total amount of carbs by the carbohydrate ratio number to figure out how much insulin she needs? Yes or no? So the good thing about the pump is that once you put the carb amount in the pump, it does all of the calculation, which you then confirm. In the last part of this presentation, we will address urgent and non-urgent diabetes management situations. Urgent situations can occur for children with diabetes since they can happen at any time when nursing may not be there, and so will require an understanding and level of involvement by school staff. To start, the symptoms of hypoglycemia are individual and is helpful if the parent communicates which symptoms are common for their child. For younger children, they may not be able to recognize the signs of hypoglycemia or how to respond. They may be distracted and not want to stop their activity, and for school-age children, they may not wish to have their peers know what's happening at the time. Continuous glucose monitors have alarms that can alert when a child's blood glucose level is predicted to be low in the next 20 minutes, and even identify when the child is currently low. It's beneficial to include the signs and symptoms of hypoglycemia, meaning of the continuous glucose monitor alarms, and how to treat a low blood sugar in the education of school staff. We'll refer to some of the websites at the end of the presentation, which are great to direct school staff to, including our About Kids Health website at SickKids. The Diabetes at School website is a great resource as it has handouts that you can see here on this slide and videos which are geared to caregivers and school staff. Although signs of hypoglycemia and treatment amounts may vary from one child to another, the steps to identifying a low blood sugar and responding should be the same. Reinforce the 3 steps with the teaching school staff. Step 1, check. Step 2, treat. And step 3, repeat. Our last case brings us back to Mohammed, who's appearing tired at school, and his Dexcom G6 reading is 3.7. It's lunchtime, and you've arrived to administer his dose of insulin. He has 50 grams labeled for his lunch today. Below are his orders, which have been slightly adjusted with an insulin to carb ratio of 1 unit to 8 grams, and then a correction scale as below. The case study questions are, what is the best approach to treating the low? A, treat with 10 grams of fast-acting carb and wait for Mohammed's blood sugar to come above 4. B, calculate the amount of carb based on the ICR and decrease it by half a unit because he's low. Or C, give the calculated amount of insulin based on his ICR right away and have Mohammed eat his lunch. So the answer is A, to treat with fast-acting carb to make sure that Mohammed's blood sugar comes up. And this is because he's at school, he doesn't have direct supervision, and it's really important that we get the blood sugar back into target, then proceed as normal with his dose calculated at lunch. When he does have lunch, encourage him to begin with his carbohydrate foods so that his blood sugar can continue to increase. And for the second question, what should be done next? A, determine the cause of the low blood sugar. B, advise the school staff of Mohammed's low blood sugar and to finish his lunch. C, communicate with the parent. Or D, all of the above. And of course, it's important to have that communication with the school. Perhaps he has gym after lunch, and also relaying this information to parents or making sure it goes home with Mohammed at the end of the day, because perhaps they might need to make a change to his regular dose of insulin to try to prevent these lows from happening if there's been a blood sugar pattern. So just to kind of progress to talking about a severe low blood sugar, and it's important to mention up front that having a severe hypoglycemia event at school is quite rare. However, it's important that all caregivers and school staff know what the signs of a severe low are and how to intervene. So hypoglycemia that requires someone else to quickly respond because the child is unable to safely eat or drink a fast-acting sugar is considered a severe hypoglycemia event and will show as symptoms outlined, including drowsiness, confusion, slurred speech, loss of consciousness, and/or seizure activity. In this case, the child requires glucagon, which is a hormone that increases glucose levels. Baqsimi, the nasal inhaled glucagon, has been a game changer and replaces the need for glucagon injections. And it seems because nasal glucagon is much easier to administer that schools are more open to giving this medication in a severe hypoglycemia situation compared to injected glucagon. So with this, we're finding there are many more requests from parents and nursing to teach how to use this medication in the school. It is approved for children 4 years of age and older and is now covered by OHIP Plus, so it's what's being prescribed to all school-age children. In teaching school staff about Baqsimi administration, there's great resources online, in particular a video link that within a minute is able to give all the instructions of how to prepare and administer this medication. Two key points to emphasize, though, are that one, you don't want to remove the shrink plastic wrap until you need to use it. And secondly, since it's a single dose medication, you definitely don't want to test it by pressing the plunger until you're ready to give the dose. These are the different steps outlined here, but again, it's definitely less intimidating for people to use, and there's been shown to be that there's less error in administering this nasal glucagon as opposed to our previously injected glucagon. Now, just to kind of switch gears, hyperglycemia in and of itself is not an acute issue unless the child uses an insulin pump. It's important to assess first how the child is feeling. If there is an illness in the context of high blood sugars, then communication with the parents and further intervention may be required. We know that when children have an illness, they have a greater need for insulin to avoid ketones being produced. In addition, it's helpful to assess whether other contributing factors, such as was their food intake, for example, close to lunch, contributed to the high blood sugar level. Was there a previous low blood sugar that perhaps was overtreated? Or is this something that you've been seeing every time you've been coming to school at lunch and perhaps the parents need to change the insulin dose at breakfast? It's helpful to communicate this information to parents so that they can make these adjustments and an updated school nursing order can be sent. Persistent high blood sugars for a child who wears an insulin pump is more urgent, as this could indicate that there is a problem with the infusion site or a pump failure. If the sugars aren't decreasing 2 hours after a correction bolus, then there is a high suspicion of a pump issue. Parents will need to be contacted about the need to change the site and give a dose of insulin by using an insulin pen. The nurse plays an integral role in the care of the children with diabetes. The nurse can address the child's progress in becoming more independent in their diabetes management at school. Communication with parents and school staff to advocate on the needs of the child for their diabetes care in the school setting is also very beneficial. The child's primary diabetes nurse is also a resource and should be available for any questions or clarification that might come up around the child's diabetes care. The school nursing referral form addresses the level of independence and length of time for support that is expected for each child. It's important to educate and engage school staff in understanding the child's diabetes care so they too can support as the child's level of independence increases. It's helpful to have ongoing assessment of the child's level of independence and communicate with the parents and the team as needed. So there are many resources that can help support the education and care that the nurse provides in the school setting. As technology and new insulins evolve, these resources can help keep you updated. In particular, I'd like to highlight the Diabetes at School website, the About Kids Health website, and the FIT guidelines. Thank you so much for your interest and involvement in supporting children with diabetes in the school setting. We hope you found this presentation valuable.